Hey everyone, we're gonna wait just like maybe another minute or two to get started, just to allow some people to trickle in. Um, Plan today is Calvin and I have created some questions based on the lectures you guys had this week. So a lot of stuff about the inguinal canal and types of hernias, as well as some artery stuff, vein stuff, and then some embryo. So we're gonna go through some questions and then we'll talk about the answers as we go through them. And if you guys have any questions throughout, just, unmute yourself or let us know. But we'll wait like maybe another minute and then we'll get started. All right, we're gonna get started here. All right, so I'm gonna read the question to you guys. We'll give you like, I don't know, like 45 to 60 seconds to think about the answer, and then we'll chat about it. So we got a 24-year-old female with right-sided abdominal pain, subjective fever, which means she's got some chills, and is worried that she has an appendicitis. You don't expose the skin to examine because you are sure of the diagnosis. To impress your attending with your elite osteopathic skills, you perform a top secret HVLA lymphatic hydro pump to cure her appendicitis, and a volcanic eruption of foul bacterial pus hits you in the face. Turns out she had a 6 centimeter abscess on her right upper quadrant abdominal wall. Which lymph node will this infection drain to? Calvin wrote this question, by the way.
It's based on a true story. All right, so explanation. A couple of you guys said C, that's correct. This slide is from your class notes. Lymphatics, you're gonna have to know this all year long. It's a favorite topic for exam questions. And sometimes the answer it's not really intuitive, right? Because you wouldn't really think your first thought wouldn't be, oh, something on the abdominal wall drains into the lymph node in your armpit. But that's why it's important to study these things specifically and just know all the specifics because they're gonna get really in detail about this, especially when it comes to the abdomen, where there's a couple of different routes for the blood to go through. So just try to be aware of that.
All right, so I can start again. So we have a 28-year-old elite student osteopath with a past medical history of lactose intolerance, presents with severe lower abdominal pain. He suffered from an extremely violent bowel movement after splurging on a 6 cheese pizza from Papa John's, 30 cannolis, and 5 pints of ice cream. On exam, there's a palpable lower abdominal mass. Your attending explains that the rectus sheath hematoma is a rare clinical entity that can be caused by a rupture of the inferior epigastric artery through trauma or excessively forceful contraction of the abdominal muscles. Where is the bleeding located?
Okay, a couple of different answers here. The answer here is B. The inferior epigastric artery is the one that ruptured, and so the bleeding would be anterior to the transversalis fascia. So this is another one that they like to talk about. It's kind of confusing. These are the slides again from your class notes. And the important thing to know here is that with your rectus abdominal muscles, your abs, right, your six-pack abs, there's an arcuate line that goes horizontally, and then above, superior to the arcuate line and inferior to the arcuate line, the fascial layers that are enveloping these muscles, they're going to be different. And the reason why that's important is that the superior epigastric artery, it comes from above, from superior to the arcuate line. The inferior epigastric artery, it comes from inferior to the arcuate line. And then the main thing to know here is that the inferior epigastric vessels, they lie anterior to the transversalis fascia. They lie on top of the anterior, excuse me, on top of the transversalis fascia. And that's, if you see the diagram on the right side, that's the second layer from the left. And because of this, because it has less protection in the back, that's why it can form a hematoma if it's ruptured.
Does anyone have any questions about the rectus sheath, the arcuate line, and how they're oriented? I know this is a confusing topic, so I just want to make sure we're good with this.
Yeah, can we go over that, please?
Sure. Can you go back like one slide? So if you guys were with me the other night, I have a mnemonic, or not a mnemonic, like a little drawing or saying that I like to do. Um, so it's 2, 3, 3, 1. Okay. And the 2 and the 3 represent the how the muscles are situated when you're above the arcuate line, and then the 3 and the 1 represent how they're situated below the arcuate line. So when you're above the arcuate line, the muscles that are going to be anterior to these rectus abdominis muscles. I'm not sharing my screen, so I don't know if you can, Calvin, could you point out the rectus abdominis muscle on the diagram? Um, the muscles that are going to be anterior to the fibers that are going to make up the rectus sheath that are anterior to this rectus abdominis muscle. When you're superior, there's going to be two of them: the external oblique muscle and then the internal oblique muscle. Behind the rectus abdominis muscle or posterior, you're going to get, and you're still above it, the arcuate line, you're going to get contributions from the internal oblique. So the internal oblique kind of wraps around the rectus abdominis muscle on the anterior and the posterior side when you're above the arcuate line. But then you're also going to get contributions on the posterior aspect of the transversus abdominis muscle and the transversalis fascia. When you drop below the arcuate line, so we're inferior to it now, there's three things in front of it and one thing behind it. The three that are in front are the external oblique, internal oblique, and the transversus abdominis muscle. So now that we're below the arcuate line, that inferior oblique muscle is no longer wrapping around the rectus abdominis. It's just sending fibers anterior to it. And that transverse abdominis muscle is no longer behind it, it's in front of the rectus abdominis muscle. So we're only left with the transversalis fascia on the posterior side when we're inferior to the arcuate line. Now, this is important because of what we were just talking about with the inferior epigastric vessels. This is where the inferior epigastric vessel comes up from that external iliac artery, comes up through the rectus abdominis, and then connects with the superior epigastric artery, which is going from the internal thoracic. Right where that space where the muscles transition from 2 to 3 on the anterior side, that's where the arteries meet. So it's a way for essentially the reason why that transition happens, for simplicity's sake, it's a way for those arteries to meet in a more convenient manner. When you guys go into lab, you can actually see this transition. Yes, thank you, Princey. That's the exact drawing that I did the other day. In lab, you can see there's like a thinning of the layers, and you can tell, okay, you're looking at the transversalis fascia because this is where it's really thin, and that's below the arcuate line. And then when you go above, it's a little bit thicker appearing. So now you know you're looking at the three things that are behind it, which are you can see in the picture here, that was shared in the chat. So internal oblique transversus abdominis and then the transversalis fascia. I hope that makes sense.
Yes, it makes sense. I was just I guess confused as well with like the blood, but I can re-go over it by myself. I don't want to. There's a lot of people here. I don't want to take up everybody's time.
Oh, I mean, we can. What part of the blood supply are you? Or we can, if you want to hang out afterwards, we can talk about it. I thought you were talking about like the orientation of the muscles. I'm sorry.
No, no, that's what I was talking about. Because in the question, I was stuck between B and C, and I was trying to figure out like, okay, so like, what is the difference? But since you went over the layers, I understand. I guess my not problem, but issue is like, how could I apply what you just said to know which layer it was?
Oh, so that's what, so the way you could apply it is based on the reason why that transition happens is so the artery itself can meet. And the question stem was describing a hematoma basically pushing into the abdomen. That occurs because below the arcuate line, the transversalis, that the only thing that's posterior to the rectus abdominis muscle below the arcuate line is a very thin layer of tissue that's made up by the transversalis fascia. That's basically what we were trying to get at with that.
Okay, perfect. Thank you so much.
Yep.
All right, let's move on to talk about hernias. Rick Ross presents to your ED with groin pain and a bulging, swelling mass in the lower abdomen. He said the bulge appeared after a particularly violent coughing fit earlier today. When asked about smoking history, he says, "I smoke, just not tobacco." On exam, the mass is reducible, it is non-strangulated, and it expands with coughing. Your attending explains that the pathway taken by a direct inguinal hernia is.
I cannot reiterate how high yield it is to know the difference between direct and indirect hernias, by the way. So we're going to talk about this afterwards.
All right, so most of you said B, and that is correct. Excellent job. The direct inguinal hernia, it emerges medial to the inferior epigastric vessels through the superficial inguinal ring at the end. Can anyone tell me what the anatomical space is called and its borders?
I can try Calvin. So that would be the triangle of Hasselbalch. Is that what it's called?
That's correct.
And the borders would be the rectus abdominis medially, the inguinal ligament as the, I think, lateral border, and then the epigastric vessels as the other border.
All right, excellent. So this is a very high yield topic, even in third year on rotations. When you're going to be in surgery, one of my friends, he said the surgeon asked him that, which was like, is direct medial lateral? He knew the answer. his buddy didn't, and one of them did not have a good day afterwards. So please remember this. So the triangle of Hasselbalch, or the inguinal triangle, this is the weakest area in the anterior abdominal wall. The reason is kind of related to what we just talked about with the arcuate line and the differences in the fascial layers superior and inferior to the arcuate line. Because inferior to the arcuate line, there's already less padding there. There's only that little transversalis fascia, and then basically your peritoneum behind it, right? That's all of your abdominal organs, your intestines, everything pressing against that tiny space. So you can imagine if your abdominal wall is weakened, right, from years of strain, from years of, let's say, very heavy weightlifting, or you're an office worker. I mean, sorry, you're a postal delivery man, right? You're always walking, always straining those muscles, always smoking, always coughing. These are things that can provoke a direct inguinal hernia through this weak point, and then from there it can enter. It can emerge through the superficial inguinal ring and into the inguinal canal. All right, great job, guys. So we'll move on to the next question. All right. So you are examining a 7-month-old male infant for cryptorchidism to determine if both testes have descended into the scrotum. You find that both of the testicles are palpable inside the scrotum, and the next thing you do is to examine for an indirect inguinal hernia. Your attending asks you to explain the pathway that this hernia takes from the abdomen to that external landmark where you can palpate for the hernia. So I'll let you guys think about this for a little bit. All right, so I'm seeing a couple different answers here. It looks like it's between A and C. So the answer is C, the indirect inguinal hernia. It goes from lateral to the inferior epigastric vessels. That's where it starts from. And then from there, it goes into the deep inguinal ring. It passes through the deep inguinal ring into the inguinal canal. And then it emerges from the inguinal canal through the superficial inguinal ring into the scrotum. And here is a diagram, again, from your class slides. This is, this one always confused me because of the terminology, but basically superficial versus deep, it's from the point of view from, you're looking at it from outside of the body. So superficial would be meaning closer to the skin, deep would be actually inside of that abdominal cavity. You might see this in other sources. Instead of them calling it superficial and deep, they call it internal, external, which I think makes a lot more sense. But in your class material, it's called superficial and deep, so that's what we're going with. So with these indirect inguinal hernias in general, they're more common in males and females because in males, testes and the spermatic cord, they descend all the way through the inguinal canal to enter the scrotum. So there's an opening there that it's not normally there, like it wasn't there to begin with, in the original female body plan. So that's why for indirect inguinal hernias, the the picture you want to think about is that okay, like this is a congenital defect in a male infant. Like it's not usually something that they'll find, 40, 50 years down the line. This is when they tell you this on the test, they want you to think that it's a congenital defect in a male infant.
All right. So we have a 15-year-old male that's presenting to the emergency department with his mother for evaluation of a sudden and severe pain in his left testicle that began 2 hours ago. On physical exam, you note the left testes is elevated, firm, and very tender. Gentle stroking of the superior inner thigh fails to produce elevation of the affected testes. What is the name of the reflex being tested and what nerve is involved? Oh yeah, so everyone got this pretty quickly, but as simple as it may seem, this is something that's likely going to come up in your test, or at least during pelvis and repro in the spring. So the this case is basically describing testicular torsion. It's a I wouldn't say fairly common, but something you'll probably see in your career, and it happens usually during puberty, like the puberty age. And for simplicity's sake, the basically the testicle is being wrapped around itself, and that cuts off the arterial supply and the venous drainage to the testes, and it can ultimately result in hemorrhage and death of the testes that's being affected. Um, so because of the twisting, that genital femoral nerve that's innervating the cremasteric muscle or cremaster muscle is no longer doing its job. It's being compressed by the twisting. So that's why you get we'll call it a negative cremasteric reflex. Normally, when you stroke the superior inner thigh, the testes are supposed to raise as a more of like a protective mechanism. Um, but if it's being damaged for whatever reason, then obviously you're not going to get that to rise. The cremasteric muscle is covered by the internal spermatic fascia, and it's actually derived from the internal oblique muscle, which always like boggled my mind, thinking that an abdominal muscle also kind of like extends down into make this muscle, but it is. Um, and the primary function of the cremasteric muscle is to aid in, like I was saying, raising the testicles, primarily for maintaining proper production of sperm because sperm require a certain temperature. Specifically, I think it's like 33 degrees Celsius. And that's why the testes embryologically descend rather than staying in the abdomen, because in order for sperm to develop properly, they need to be at a lower temperature, which I think you guys will probably get into more in pelvis. But regardless, that you guys hammered this one, so nice. All right. So we have a 65-year-old male patient presents to his family medicine physician for evaluation of painless swelling in his left scrotum that began a few months ago, but has only worsened. A testicular ultrasound confirms hydrocele and dilation of the pampiniform venous plexus on the left side. Further workup reveals renal cell carcinoma of the left kidney. Which of the following statements best describes the anatomical relationship of the patient's initial presentation? All right, so we got a couple of different answers here, and that's okay. This is definitely another highly testable topic because it's kind of similar if we go back to the vagus nerve and how it's different on either side, where the recurrent laryngeal nerve is looping around, and that's why they love testing this. So the testicular veins drain into two different spots, depending on or they drain into different spots depending on the side. So if you want to go to the next slide, Calvin, I have a picture. The left testicular vein drains directly into the left renal vein, and then that vein, the left renal vein, will drain into the inferior vena cava, whereas the right testicular vein drains directly into the inferior vena cava. Um, it, there's no real good way to be like, oh, this is how you can remember it. I just think this is one of those things that you're gonna have to memorize. If you think it's not that important, I'm telling you this question I wrote because this is something that we're getting tested on as second years. Renal cell carcinoma loves to invade the renal vein in the IVC, and a common presentation for renal cell carcinoma is swelling of the testicles because if you block that testicular vein at the renal vein or at the most proximal portion, you're going to get backflow and the fluid can't go anywhere. So the testes are eventually going to start swelling. So that's just one of those things to keep in mind, the different orientation of the vessels. Now, some people put the portal system, and I just want to make a quick point for that. The portal venous system is definitely important, and you're going to cover that extensively in the next couple of weeks because the organs drain, the venous system drains slightly differently depending on where you're at in the abdomen. So I just wanted to say as like a preview that is commonly associated with like the liver and digestion and things like that. But there can be some crossover between the cable and the portal system, which you guys will get into in a couple of weeks. All right, so another lymph node question, and the reason why we did a couple lymph nodes is because they love testing lymph nodes. So we have a 23-year-old male patient who was recently diagnosed with left-sided testicular seminoma. If the cancer were to spread, what lymph node would the cancer likely drain into? All right, so we're going to talk about this too. A few of you guys got this right, but this is the para-aortic lymph nodes. So this is one of those things, unfortunately, that you're just going to have to memorize. While I was muted a second ago, Calvin and I were just chatting about our anatomy exams last year, and for whatever reason, not whatever reason, there is an important reason, but during the abdomen and pelvic specifically, those exams, there was a lot of lymph node questions. And I remember as a master's student, I neglected the lymph nodes because like, there's no way they're going to talk about this. And I got a lot of questions wrong my master's year. First year, on the other hand, I was prepared for the lymph nodes, let me tell you. So the the lymphatic drainage for and you can go to the next slide, Calvin, but for the testes themselves are the para-aortic lymph nodes. And the way you can kind of think about this is because the testes originally start in the abdomen and then they descend. So all the vasculature, the veins, the arteries, the lymph are going to start where the testes are starting. And as we just discussed, the testicular veins, one goes into the IVC, one goes into the renal vein, but the testicular arteries come directly from the aorta. And the lymph nodes, most of the time, are going to follow the artery supply. So if you can remember that the testicular artery, the gonadal artery, comes from the aorta, it'll be pretty easy for you to remember that the the testes drain into the para-aortic lymph nodes. Another one that was in your slides was the lymphatic drainage of the scrotum. And the way you can think about this is that the scrotum itself is like a skin extension of the pelvis. It didn't originate in the abdominal cavity like the testes did. So that's going to drain into lymph nodes that are like adjacent to the skin, being the superficial inguinal lymph nodes. Um, and you'll learn more about the like the penis itself and like where the drainage is when you get into pelvis. We can spare you for that with that right now. But just to recap, the testes are supplied by the testicular artery, which comes from the aorta, and the lymph nodes drain into the para-aortic lymph nodes, which are just outside of the aorta. And you can remember this because the testes start inside the abdomen and eventually descend. And then finally, like I said, the scrotum, think of that as just like a skin. I mean, it literally is just like a skin pouch. So it's going to go into something more superficial, being the superficial inguinal lymph nodes. So nice job. So now we're going to go into everyone's favorite. We're going to do a little embryo. And I know everyone's super excited to talk about some embryo. So we have a newborn has recently been placed in the NICU. The patient was born 2 days ago and has not had a bowel movement despite normal feeding since delivery. On exam, the patient has a severely distended abdomen and appears lethargic. An abdominal x-ray is done, and it should say it shows a dilated megacolon. What is the mechanism behind this condition? Sorry about the typo.
T. B.
All right, yeah. So a lot of you picked the correct answer, and some of you gave me the name of the diagnosis for this. So this is Hirschsprung's disease or Hirschsprung disease. And basically what happens with Hirschsprung's disease is you don't get neural crest migration. And what can happen is basically the neural crest cells, you're going to learn a lot more about this in neuro, so I don't want to get like bogged down, but neural crest cells, they originate in the neural tube and then they migrate to certain areas in the body and have pretty unique functions. The way I like to remember is that they're not like the cells that are produced by neural crest cells are not, they're very unique in what they do. Like for example, melanocytes, those are like unique cells in your skin that are responsible for pigmentation. That's a pretty unique characteristic in their neural crest cells. So for this particular condition, the neural crest cells are going to make up the cell bodies of the postganglionic. They're going to be the postganglionic parasympathetic cell bodies. And why that's important is that the parasympathetic system is responsible for, you guys know, rest and digest. You need to be able to digest your food when you're not running from a bear. So if those are not working properly, your colon is not going to be able to essentially move any food that you eat through the system. And it's essentially just going to keep building up food, building up food, building up food until eventually you get a severely dilated colon. And this is called Hirschsprung's disease. Now, Hirschsprung's disease has other manifestations aside from a dilated megacolon, and you guys will learn about this more in neuro, but this was in your guys' slides, and this is something that they could definitely test you on. Last point before I move on, and this is directly from Dr. Mormon's mouth. Last year, he said if you see an answer that's related to neural crest cells during anatomy, basically pick it. So, and I think that pretty much held true for all the exams that had something related to neural crest cells. All right. So keeping it going with oh, sorry, we have a question. How would we rule out an imperforant anus? That's a good question. So an imperforant anus is not necessarily going to cause a toxic megacolon. The main thing was that first of all, the imperforate anus is basically, how could I describe this? There's a membrane that doesn't break, like the ectoderm and endoderm don't fuse properly. Because if you go to what's the line called? above the line is the endoderm, below the line is the ectoderm from embryological function, and that doesn't fuse properly. From my understanding, though, you're not going to get as severe as a megacolon this quickly as you would in a perforate anus. All right, so we have a newborn has just been delivered and appears to have a herniation of the abdominal viscera that is not covered by peritoneum or skin. The patient is immediately taken to surgery given the severity of the condition. The improper closure of the anterior abdominal wall was likely caused by what mechanism, and what is the name of this condition? All right, so we got a couple of different answers here, and this is definitely going to be in your test. This is what I think they tested. They did either, so some of you picked A, and that's the closest choice, but it's not quite correct. So I'm going to butcher how you pronounce this, but the omalphiceal is it is also a hernia that's similar to gastroschisis or however you say it, but the main difference is that with the gastroschisis, I'm butchering it. I'm sorry, but the main difference is that the mechanism is different, of course, but the viscera in gastro, you guys get what I'm trying to say, is fully exposed to the environment. So there's nothing protecting the intestines essentially from the environment at all, and it's actually can be fatal. In up to 10% of cases, it's fatal, according to the slides. Whereas with the omalphiceal, that is protected somewhat by the amnion, but there is no skin or muscle. So I guess the main way you guys can differentiate it just from a clinical standpoint is gastro has absolutely nothing on it. It's fully exposed. Whereas with the omophallocele, it's not fully protected, but it does have some protection from the amnion. Now, the from a developmental perspective, gastro is caused by failure of the bilateral somatic lateral plate mesoderm to properly fuse. So I'm sure you guys can remember during oh, maybe you don't, I barely remember it. From the first couple of weeks, you have all the folding going on, the craniocaudal and lateral folding. Basically, what happens during the folding is that lateral plate is going to fuse with each other in the middle. And if that doesn't happen, the viscera can herniate out. Whereas with the omophallocele is the midgut doesn't return into the body cavity. So during development, the midgut, which gives rise to a number of things which we're going to get into in a little bit, it kind of it partially herniates through. So it sounds counterintuitive, but the midgut is going to stay connected to the vitelline duct, and during for an extended period of time, it does remain essentially outside of the body. But as the intestines start to rotate and get into their proper orientation inside the abdomen, it's essentially going to pull the midgut back in while it's rotating around the umbilical arteries. And if it doesn't rotate as it's, if it doesn't get pulled back in while it's rotating, you can get the omophallocele or however you say it. I hope that makes sense. So with the Meckel's diverticulum, that's not a herniation or that's not the viscera being out on the outside of the abdomen. Basically, the Meckel's diverticulum is it's similar to what I was just describing with the omophallocele, where during the proper folding and the proper rotation of the intestines, instead of it staying outside, it does end up back inside the body cavity, but the ileum itself, it kind of anchors to the anterior abdominal wall, and that creates an opening between the umbilicus or belly button essentially and the intestine. So after delivery, that adhesion between the ileum and the anterior abdominal wall can cause feces to be excreted through the belly button. So I can see why you might have thought Meckel's diverticulum, because it is semi-related to something being related to the twisting and the intestine getting pulled back into the body cavity. But the main difference is that in Meckel's diverticulum, the intestines end up back in the body cavity. It's just that it's like slightly stuck to the anterior abdominal wall. Whereas in ophthalmocele, it's doesn't make it back in. It ends up staying outside, but it's covered with some layers to protect it. All right, I think we can move on to the next one. Oh, and this is just the on the left-hand side, that's literally from your slides, and then the right is an unfortunate little baby that has gastroschisis, and you can see that there's nothing covering the the intestines. There's no skin, no peritoneum, no amnion. Whereas with the ophthalmocele, you're going to see kind of like a almost like a thick white layer on top of it. All right, here we go. So we have a 55-year-old male patient presents for evaluation of upper abdominal pain and severe acid reflux. On endoscopic evaluation, the patient is found to have several gastric ulcers near the pylorus of the stomach. Which of the following correctly describes the embryologic origin and the arterial supply to this organ? All right, nice job. So this one should be pretty straightforward, but there's definitely going to be, I don't want to say definitely, but there's likely going to be at least one question on this. So knowing the derivatives of foregut, midgut, and hindgut are incredibly important. I think one of the questions last year was like literally like it was like a one-liner, it was like which of the following is like a derivative of the hindgut. So you do need to know these derivatives. It is kind of intuitive because if you remember what the blood supply, like which one gives off what blood supply, you just need to think about, for the most part, what organs are supplied by that blood supply, and you'll be able to get the answer right. So for those of you that attended on Tuesday, I briefly went over the all the arteries in the abdomen. I know it was a little premature, but I think it was worth going over. So if you recall, the celiac trunk, which is at the level of T12, is right below the diaphragm. So think about, first of all the organs that sit right below the diaphragm. Um, and if you can even dive into the diagram, think about all the branches of the celiac trunk and where they're going. So they're going to the stomach, they're going to the pancreas, they're going to the duodenum, they're going to the liver, they're going to the gallbladder. All of those things are foregut derivatives. The one that's like kind of a little confusing. There's two that are a little confusing that you kind of have to remember the exceptions is that for the midgut, the duodenum is also part of the duodenum comes from the midgut. It's the distal duodenum, and that does technically get some blood supply from the superior mesenteric artery. Okay, if you guys remember from the inferior pancreatic duodenal artery that comes up. So that's one exception where you kind of have two things going on. And then in the hindgut, if you recall from the blood supply that I talked about the other day, the rectum and the upper anal canal are the ones that are a little funky. So the rectum, the it is done by hindgut. You have to memorize that it's from the hindgut. But the reason why I'm saying that this rule is a little confusing, and just to review a little bit, is the middle rectal and inferior rectal arteries come from the internal iliac arteries, not the IMA. But the superior rectal artery still does supply the rectum, which comes from the IMA. And then the upper anal canal, um, just think of that as a continuation of the rectum rather than thinking of it as something separate.
the word that I was trying to use earlier and I failed to remember is the pectinate line. So above the pectinate line, that is endoderm derived, and that's closely associated with the rectum. Below the pectinate line is ectoderm, and that's why if you have like a hernia, you can like it's an external hernia. That's why it's painful because ectoderm has pain sensation, whereas endoderm does not. So the upper anal canal, think of that as above the pectinate line. That's going to get from the IMA or hindgut, and then below is ectoderm, and that's not related. I hope that makes sense. All right, this is our last question. So we're on we're doing good on time. So we have a 2-day-old female develops persistent vomiting shortly after feeding. Extensive evaluation, including imaging studies, shows a double bubble sign suggesting a duodenal obstruction. Surgical exploration reveals pancreatic tissue encircling the duodenum. What developmental error best explains this condition? All right, so some of you got the answer correct, and the answer is A, bilobe ventral pancreatic bud migrating in opposite directions. Now, before I explain this, I want to talk about a couple of other things that you might have been thinking about initially before we got into the surgical exploration portion of the STEM. So there's a couple of things that can cause persistent vomiting, drooling, etc. after feeding in a newborn that you do have to know for your exam. So during the development of the esophagus, there's the recannulization where the epithelial cells die. Um, if that fails for whatever reason, obviously the baby is not going to be able to feed. If you have excessive amniotic fluid, that can also cause blockages in the esophagus, and that's going to cause the baby to not be able to feed properly. A common one is pyloric stenosis. So if there's thickening of essentially the junction between the duodenum and the stomach, that's called the pylorus. If there's thickening of that for whatever reason, that can also cause the baby to be violently, projectile vomit violently. Usually with that on a clinical exam, in addition to the vomiting, you'll feel, they call it like an olive-sized mass in the epigastric region. I've actually seen this before a couple of times. When I shadowed a family med doc, and there was a couple of newborns that had pyloric stenosis, so it's pretty common. Um, but for this particular question, we gave you that, okay, they did surgical exploration based on the severity of the obstruction, and you can see that the pancreatic tissue is circling the duodenum. So why does that happen? So during development, there's a dorsal and ventral pancreatic bud that are kind of on either side of the duodenum. The ventral one, I believe, is on the hepatic side. And so initially during development, the esophagus, stomach, and duodenum are essentially like one straight tube, and they need to rotate and fold slightly on itself to get into proper orientation. So while they're rotating, essentially the rotation causes those two buds to come together on the backside of the duodenum, and then they fuse and they become the pancreas that we all know. They don't like fully fuse, but they cause the lobes to be in the proper orientation. But in an annular pancreas, which this is what this is describing, the during that rotation that I was describing, because remember, if you look at the pictures too, you can see the esophagus, stomach, and duodenum are all one long tube, and they need to rotate and get into the proper orientation. If there's an annular pancreas during the gut rotation, one of the buds goes posterior while the other one goes anterior, when they should both go posterior and meet in the middle. So you can imagine if one thing is wrapping on the front and one's wrapping on the back, it's basically like putting your two hands around the duodenum and squeezing. Um, So that causes a bilobed ventral pancreatic bud that goes in the wrong direction. So that's I don't have an explanation slide. I can add it before I send out, but that's long story short, there's a ventral and a dorsal pancreatic bud. They're on opposite sides. They need to meet in the middle during folding and the rotation of the abdominal structures. If one goes in the opposite direction to the other, meaning the buds, they can cause stricture of the duodenum. So that's all Calvin and I have for you today. I hope this was somewhat helpful. If you guys have any questions for Calvin and I, we can hang out for a couple of minutes here. But otherwise, this was my last TA review for the or last office hours for the year. So thank you guys for joining.